Many people pick at imperfections on their skin or become preoccupied with removing some unwanted hair from time to time. People with trichotillomania and dermatillomania, hair pulling disorder and skin pulling disorder, experience these behaviors to such extremes that it disrupts their lives, causes them distress and shame, and sometimes alters their appearance. Trichotillomania and dermatillomania are both body-focused repetitive behaviors categorized under obsessive, compulsive, and related disorders in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5. Trichotillomania, compulsive non-cosmetic hair pulling, and dermatillomania, compulsive skin picking, are two of the many body-focused repetitive behaviors in which a person can cause harm or damage to themselves or their appearance. Other body-focused repetitive behaviors include biting the insides of the cheek and nail biting. Compulsive hair pulling results in noticeable hair loss or bald patches. Hair can be pulled from any side of the body, with areas that are most easily reached being the most likely sites. Teens and adults who suffer from hair pulling experience intense shame and distress. They may avoid activities that they fear will reveal their hair loss, such as being outside on windy days, standing near people taller than themselves, exercise classes, or going to hairdressers. Those who suffer from trichotillomania often incorrectly fear that hair pulling must indicate that they are especially sick or self-injurious because they are unable to stop. Scientists and therapists who are familiar with hair pulling and skin picking know that these behaviors are a habit that is probably caused by a genetic predisposition that accidentally becomes self-reinforcing. So let's take a closer look at them. The term trichotillomania was first described as a medical syndrome by the French physician Halepo in 1889. In a subsequent report published in 1894, Halepo elaborated on his characterization of trichotillomania, noting the essential characteristics of the disorder as including a type of insanity that leads the patient to seek relief from intense itching by chronic, self-directed hair pulling. Despite Halepo's initial description of trichotillomania over 100 years ago, a relatively small body of research existed about the condition until recently. In the past 30 years, the body of behavioral literature regarding trichotillomania has grown, along with our understanding and ability to demystify this type of insanity. Behavioral research has led to the development of empirically based treatments for hair pulling, along with an improved awareness of the course and nature of the disorder Halepo labeled trichotillomania. In the DSM-4, trichotillomania is classified under the general category of impulse control disorders, not elsewhere classified. Now, about the diagnostic criteria, we have to mention the following. A. Recurrent pulling out of one's hair, resulting in hair loss. B. Repeated attempts to decrease or stop hair pulling. C. The hair pulling causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. D. The hair pulling or hair loss is not attributable to another medical condition. E. The hair pulling is not better explained by the symptoms of another mental disorder. Now about the diagnostic features, we need to say that the essential feature of trichotillomania is the recurrent pulling out of one's own hair, criterion A. Hair pulling may occur from any region of the body in which hair grows. The most common sites are the scalp, eyebrows, and eyelids, while less common sites are axillary, facial, pubic, and perirectal regions. Hair pulling sites may vary over time. Hair pulling may occur in brief episodes scattered throughout the day or during less frequent but more sustained periods that can continue for hours, and such hair pulling may endure for months or years. Criterion A requires that hair pulling lead to hair loss, although individuals with this disorder may pull hair in a widely distributed pattern, for example, pulling single hairs from all over side, such that hair loss may not be clearly visible. Alternatively, individuals may attempt to conceal or camouflage hair loss, for example, by using makeup, scarves, or wigs. Individuals with trichotillomania have made repeated attempts to decrease or stop hair pulling, criterion B. Criterion C indicates that hair pulling causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The term distress includes negative affects that may be experienced by individuals with hair pulling, such as feeling a loss of control, embarrassment, and shame. Significant impairment may occur in several different areas of functioning, for example, social, occupational, academic, and leisure, in part because of avoidance of work, school, or other public situations. Now about the prevalence, we need to say that in the general population, the 12-month prevalence estimate for trichotillomania in adults and adolescents is 1% to 2%. Females are more frequently affected than males at a ratio of approximately 10 to 1. This estimate likely reflects the true gender ratio of the condition, although it may also reflect differential treatment seeking based on gender or cultural attitudes regarding appearance, for example, acceptance of normative hair loss among males. Among children with trichotillomania, males and females are more equally represented. Trichotillomania is associated with distress as well as with social and occupational impairment. There may be irreversible damage to hair growth and hair quality. Infrequent medical consequences of trichotillomania include digit purpura, musculoskeletal injury, for example, carpal tunnel syndrome, back, shoulder, and neck pain, blepharitis and dental damage, for example, worn or broken teeth due to hair biting. Swallowing of hair may lead to trichobezoars with subsequent anemia, abdominal pain, hematemesis, nausea and vomiting, bowel obstruction, and even perforation. Now, about the comorbidity, we need to say that trichotillomania is often accompanied by other mental disorders, most commonly major depressive disorder and excoriation, skin picking disorder. Repetitive body-focused symptoms other than hair pulling or skin picking for example, nail biting, occur in the majority of individuals with trichotillomania and may deserve an additional diagnosis of other specified obsessive, compulsive, and related disorder, for example, body-focused repetitive behavior disorder. Now, about the diagnostic criteria, we need to say that are the following: A, recurrent skin picking resulting in skin lesions; B, repeated attempts to decrease or stop skin picking; C, clinically significant distress or impairment in social, occupational, or other important areas of functioning; D, the skin picking is not or another medical condition; E, the skin picking is not better explained by symptoms of another mental disorder. The most commonly picked sites are the face, arms, and hands, but many individuals pick from multiple body sites. Individuals may pick at healthy skin, at minor skin irregularities, at lesions such as pimples or calluses, or at scabs from previous picking. Most individuals pick with their fingernails, although many use tweezers, pins, or other objects. There may be skin rubbing, squeezing, lancing, and biting. Now, about the diagnostic features, we need to say that the skin picking causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. Distress means negative affects that may be experienced by individuals with skin picking, such as feeling a loss of control, embarrassment, and shame. Significant impairment may occur in several different areas of functioning, for example, social, occupational, academic, and leisure, in part because of avoidance of social situations. In the general population, the lifetime prevalence for excoriation disorder in adults is 1.4% more of individuals with the disorder are female. This likely reflects the true gender ratio of the cognition, although it may also reflect differential treatment seeking based on gender or cultural attitudes regarding appearance. The majority of individuals with these conditions spend at least 1 hour per day picking, thinking about picking, and resisting urges to pick. Many individuals report avoiding social or entertainment events as well as going out in public. A majority of individuals with the disorder also report experiencing work interference from skin picking on at least a daily or weekly basis. A significant proportion of students with excoriation disorder report having missed school, having experienced difficulties managing responsibilities at school, or having had difficulties studying because of skin picking. Medical complications of skin picking include tissue damage, scarring, and infection, and can be life-threatening. Rarely, synovitis of the wrist due to chronic picking has been reported. Skin picking often results in significant tissue damage and scarring. It frequently requires antibiotic treatment for infection, and on occasion it may require surgery. Excoriation disorder is often accompanied by other mental disorders. Such disorders include OCD and trichotillomania, as well as major depressive disorder. repetitive body-focused symptoms other than skin picking and hair pulling. For example, nail biting occur in many individuals with excoriation disorder and may deserve an additional diagnosis of other specified obsessive, compulsive, and related disorder. For example, body-focused repetitive behavior disorder. About the therapy, habit reversal is a multi-component treatment for habit behaviors. It has been identified as the most efficacious treatment. Generally, the 4 phases are awareness training, competing responsive training, motivation enhancement, and generalization training. Cognitive behavioral procedures. The emergence of cognitive behavioral models is likely a reflection of a movement with mainstream psychology, but also concerns regarding the universal use of the habit reversal treatment package.